who are on antipsychotic medication. So, first thing in the realm, antipsychotic drugs are not specific for schizophrenia. They are not specific. They are used in any other type of psychotic disorders. Okay? Schizophrenia is the FDA indication for that when you bring a drug to market. There are some drugs that are approved for schizoaffective disorder. I know we did not cover schizoaffective under DSM-5, but it does exist, and basically you have mixture of symptoms of schizophrenia, and then with Dr. Cohen, an affective disorder. You either have a mood disturbance, like depression, in that aspect. So they would call those patients schizoaffective. Okay? And then you have folks who are straight bipolar or with straight depression. And bipolar patients in their mania, which we'll talk about next week, that are also have psychotic symptoms when they go to full-blown mania. Okay? You can't tell the difference between that psychosis from a patient with schizophrenia. And then for dementia, they have BPSD. They call, I have to look up, I'll have that acronym for you, but it's very common where you have patients with behavioral psychotic symptom disorder associated with dementia. Okay? And so you see that in low doses. And of course, there's a big FDA warning about the use of antipsychotics in those patients of increased fatalities, big black box warning. But that doesn't dissuade folks. And then these drugs are also used for personality disorders. I mentioned in DSM-5, that would be under the multi-axial system of axis 2. Okay? Typically, low doses are used for borderline personalities. And when I say borderline, these are folks who have folks that are just kind of borderline behavioral problems, but not full-blown psychosis. They're functional in society and that sort of thing. So those are the things you think about. And that's very difficult to treat with a drug. And to give you an idea, when you group it with axis 2 and personality disorders, one of the big axis 2 that, of course, we don't really talk about in this class because it takes an hour to talk about all the personality disorders, but there's no drugs that really effectively treat them anyway. One of them is narcissism. Can you imagine any drug that takes away a narcissistic person? It won't. It just doesn't happen, okay? So that's why we don't talk about drug therapy for those folks. You can't do anything about it, okay? There you go. And then there are other medical conditions that have psychotic symptoms. One of the most common ones are ICU psychosis. You'll see these drugs used a lot in the ICU, keeping in mind they're disoriented, they could have delirium, they're pulling out their tubes, they're agitated, remember that term? They need to be calmed down and sedated. Antipsychotic drugs are very commonly used. They don't like to use benzodiazepines very often in that circumstance because typically some of those folks, you could put them into CNS respiratory depression in the ICU. So that they don't want to do. So they use low-dose antipsychotics. Okay? All right, so terminology. The old terms you'll see in the literature and your textbook even still uses the term neuroleptic. Neuroleptic. Isn't that interesting? That is not in Webster's dictionary. It means neurons, and you do something to the neurons to calm them down, the leptic part. All right? When that is mentioned, the old term, it's usually reserved for the first generation agents, such as your chlorpromazines, haloperidols, things that the doctors Pong and Emmett talked about. And part of the original aspects in the 60s was to really looking at those positive symptoms. However, they noticed in many patients treated with that, there was psychomotor slowing, sedation, all those side effects we'll talk about. In emotional quieting, sometimes you want that, but long-term wise, you don't. Remember, the goal is to return a patient back to society and hopefully functioning. And then they notice these antipsychotic drugs, the older ones, cause affective indifference, meaning that they didn't really work for those negative symptoms. Remember those A words, and that's where you see that here. So then we fast forward into the 90s, and we came up with the first atypical antipsychotic, which was risperidone in this aspect. And it was originally developed because they noticed a lower risk of the extrapyramidal side effects. That was the original intent. Now, but they also noticed that these atypical agents were effective against the cognitive and negative symptoms. That is actually a good thing in this aspect. They noticed that the atypicals had a lack of effect on the endocrine system, but specifically prolactin. And then they noticed that perhaps some of these atypicals are effective in, quote, treatment-resistant patients. And again, it's very interesting, that particular terminology, because it means a lot of different things to clinicians. But we'll go with the FDA version right now, okay? And when we get to treatment resistance later toward the session, we'll have a very fascinating discussion about that, okay? All right, so again, this is another way of looking at that. We have the older antipsychotics. These are a couple other bullet terms. Sometimes they call them conventional, sometimes they call them typical, or first generation, okay? The newer atypicals, sometimes they call them serotonin, dopamine. Atypicals are second generation. So you'll see each of these terms depending on which paper you read. So just to keeping in mind the terminology of this. All right, so this is your suggested algorithm. And let me walk you through this, okay? And again, even though it's got a fair number of boxes, it makes really common sense, okay? First of all, you have a patient with suggested schizophrenia. Remember, they have to fulfill DSM-5 criteria, right? Minimum of how many months? 6 months, right, of those positive symptoms, and then level of dysfunction and all wonderful things. So stage 1A would be the first episode. You got that first break in a patient with schizophrenia, okay? Now, rule of thumb, with the exception of clozapine, there's no other denotation that says any antipsychotic drug is more efficacious than another. And we'll show you the study that denotates clozapine. So when you have all these newer atypical agents, it's going to be based upon their side effect profile and their patient profile. Okay? So it's a very similar drug selection process they do for the anti-seizure drugs. You try to match the drug with the patient. Okay? So that's first episode, first break. Stage 1B means if the patient is a return patient, meaning that they've stopped their medication or they had a breakthrough psychotic episode or any previous exposure to an antipsychotic drug. Then you have to look at their history, what they were treated with, and then it says basically the same thing. Voila, any antipsychotic drug except clozapine. So again, that you match the patient with what you have with safety and efficacy. And we'll talk about that aspect when we get to side effects, okay? Then when you progress to stage 2, it says if the patient had an inadequate response to an antipsychotic drug in stage 1. So the question then becomes, how do you know this, right? Well, typically what you have in treating patients with these drugs, you titrate them up to a good dose. You start at low, go up every few days, okay? You hit about midway to 2/3 of their max dose, which will show you the max dose range in a minute or two. Then you balance that versus side effect. If there's a smidging of improvement, which we'll talk about when you see the acute versus stabilization, you keep going until you have side effects. This is where the art versus the science of drug that comes in, okay? And then, of course, when the side effects become too much, or when you get to the max dose and you're still not getting the clinicians feel that they're getting the full benefit, then they'll switch the drug. And then, of course, how you switch the drug becomes another process, okay? So that's stage 2. Then you could see if you want to switch them, you could switch them to any other antipsychotic drug, all right? Except clozapine. We're getting back to that again, same box. Excuse me. And then